Okay, we are now live streaming. Over to you, Sophia. I wish you a
Thank you so much, Paulo. So good morning all. Good morning to everyone who's watching us online. We are
everybody.
Thank you, Paulo. So we are starting today the day 4 of our Europe India Digital Health Week, organized by Health Data Forum with the partnership of GD Hub in Geneva. And we are very pleased to have assembled a very good set of brilliant minds to speak a little bit about geospatial data today. Thank you so much for accepting our invitation, and I hope you all have a good morning. I'll be here throughout the morning to help with any technical issues, but I'll leave the talking to you. Thank you so much. And we are going to start with Professor Prashant. Thank you.
Thank you, Sophia. And I'm filling in for Ravi. If he connects, he can take over. So welcome to the Europe India Digital Health Week. So this session is on how geospatial technologies is being used in different various scenarios in health, and we have a amazing set of panelists today, and we'll go over a little bit in that. And so this is what we have set up the agenda. Uh, so I'm filling in for Ravi a little bit, and then we'll have Stefano give his presentation on Earth observation for health activities with focus on Europe-India collaboration. And we have Mr. Jojo Mehra, who's from E-Governance Foundation in India, and he'll be talking about the Digit Health Campaign Management, which they have been doing a lot of work in India and in Africa. Then we have Cyrus talking about Happy Baby, Kushi Baby, and the work they're doing with the Ministry of Health and Family Welfare in state of Rajasthan in India. Then we have Dr. Nandini Menon, who's very well known for her infectious disease work that she's done over the years, and she's the real professor. And the work, Nandini Menon, will be working on will be talking about geospatial applications for public health in India and environmental perspective. And Dr. Jayanti Shastri will be talking about the work that they've been doing in the context of leptospirosis and outbreak in Mumbai. And then we'll have a panel discussion, which we want to make it interactive as much as possible. We'll have questions, and we'll also have the panelists talk to each other, and then we'll have a closing few minutes by Ravi. So I'll just move to our GIS Center. So our GIS Center was officially launched in 2022 in May, and this was a big event we had in Geneva. So GIS has been used in WHO in many different outbreaks and in different departments, divisions. Many efforts have been put in, especially for the Ebola and the polio eradication work. And it was decided that we need to have a centralized GIS to support all the country offices and the regional offices. So we officially started in started in April 2022. 2020, and but since it was the pandemic time, we all work remote. We are a large team of 40 plus people, and I'll go over that a little bit. And we support the country offices and that, as I mentioned, the regional offices as well. So our large part of our work is advocacy work, which is having bilateral meetings. We also attend the key UN meetings on geospatial knowledge and across UN agencies. We attend conferences, and we also have our events, and we have a presence in, as I mentioned, the 194 country member states are there, and we try to support them, which are divided into 6 regions. We also provide technical support. We have a large map requests that come in, and we help them in various ways. We work on projects such as the big snake bite project we worked on for a few years, and then we support the health emergencies and any outbreaks, and even in health facilities mapping and identifying areas that are affected by, could be because of natural disaster or social unrest or political conflict. We also do a lot of planning. We support our countries in their planning of the GIS uh, strategy for the country, because every country is different and every outbreak is different, and so we customize it based on that, and we work very closely with them. Currently, we are doing a large micro planning project in Bangladesh. Uh, and then, of course, a large part of our work is capacity development and working with improved capacity among the country officers. And Inge, who's in this session here, is one of the persons who leads that program. So we do workshops, we do in-country trainings, we do online trainings. We also do webinars. We call them knowledge series, where we bring in experts and they talk about specific areas of work. We've had people from all over the world talk about. We do that once a month, knowledge series, and then our trainings are known as the learning series, which could be based on a specific software, then the field data collection, and or open source GIS, online GIS, and story maps, cartography. We do all this. We also have office hours, and we support our country offices with any questions they have whenever on Thursdays, and we also do mentoring, and we have people sent on missions to support. And like the Horn of Africa, we had several years of support for Horn of Africa drought and flood response, in Sudan crisis, and in Palestine, Israel also. We have had a few successes with in-country setting up. This is the GIS center in Somalia. The picture you see on the right, upper right, which is the first country to have a GIS center. It's supported by Gates Foundation for the polio work, and then also to be extended to other divisions such as the malaria and other routine immunizations and everything. We had last year in November, we had a European Euro office had their first GIS geospatial coordination hub in Istanbul, and that also gave us a chance in July to bring in all the GIS people from different parts of the world from WHO. And of course, these are the what we're trying to do is bring in a GIS culture in terms of thinking GIS, because that opens up the spatial patterns that we see around in various outbreaks, and um, and the response that we want WHO to do should be based on data and analytics, and that's the large part of it, is to get the geospatial thinking in the various programs. So we also do this. This is something that micro planning work that we've been doing. We have these 4 areas of place where we have divided our work into GeoPlace, which is the gateway for geospatial data, and we also have this geo-enabled workspace where where we bring in all the information, data, analytics, and then it's the workspace that we provide where all the information from the GeoPlace comes in. And GeoMart provides the baseline infrastructure, that hardware, servers, software, and then lastly the GeoHub, where visualization and dissemination, everything comes together. We divide our work in several ways. Ravi, I see that you are here. You want to take over?
No, Prashant, I think you're doing a good job. Just maybe I can start from here. Thanks, and sorry for
Thanks,
being
Ravi.
late. This being a digital event, it's little awkward to be not able to connect on time. Yeah, as Prashant said, that this is a lot of people come and ask us. You're talking about GIS. What do you guys actually do? What do you guys actually do in the field, or what do you guys? How are you guys engaging with the ministry? Our key focus is the Ministry of Health, right? We are serving them. WHO is an organization with 194 member states, mainly to serve these member states. And I I put this in these 4 boxes, geoplace. That is how the data comes in. Any data which is captured has a locational capability with it. So we are making a lot of efforts to collect that location. I'll tell you an example. In COVID data, we have more than 750 million case records in a database stored somewhere in WHO. Every member state on a daily basis, on a weekly basis, has submitted this data. There is rich information about the location there, but it's very sad to see that more than 50% of the case records will not be able to, we are not able to map them. That's why we are putting importance on geoplace. When the data is collected, how do we help? How do we enable that capturing of the location? The location could be the place of residence, the place where he got or a person got infected or where he contacted with the disease, the place where the person got treated, or the place where he got hospitalized, and finally if there has been any incidents of death, because there's location associated with everything. As people say, there's a time and place, and the cases play the key role in this. Geo workspace is the enabling space like ArcGIS, QGIS, R, all these applications and softwares which we are supporting the member state and the WHO country offices, enabling them to do their work properly. And MART is, as Prashant said, it is the baseline infrastructure, the servers, the digital infrastructure to enable them to do their, finally, it's a dissemination and visualization part. Can we go to the next slide, Prashant, please? Yes, this is a very good summary I thought that we could show here. A lot of people ask, where do you guys operate right now? Which are the countries you're working? This is sort of 15, 16 months of summary where we are balancedly working with emergencies as well as non-emergencies. We have been supporting Ukraine, Gaza, Sudan, South Sudan crisis, Niger, Sahel crisis, Haiti. So many of these crises, we are engaging and we are helping in the area of GIS. And we also have a lot of flagship projects within the organization, which we support them or which we lead them. There are some things which we actually lead them. And most of our work activities happen in the field. That's why deployment is a key important thing for us. And finally, the training and capacity building is also a big aspect for us. Can we go to the next slide? Yes, I'm going to talk about, there's only 3 more slides about various tools which we are using to see how it shapes up our work. One tool which will be very important and interesting is access mode. We call it as an access mode. It's a very old tool, 20 years plus it has been in WHO. It is as simple as to know the drive time to the nearest health facility, or conversely, how well we are serving our population. Within 15 minutes radius, how much population are we covering compared to the population which are very far away? Because our access is to, our objective is to give uniform access or service delivery to the population. So we have this measure, and we are doing a lot of work on this, and we built this tool, and this has been put into different use cases. For example, in snake bite, where should we keep our anti-venom stockpiles so that people could access it to the nearest facility? So that sort of analysis in terms of bed net distribution for malaria. Are these an equitable thing? Even during COVID time, we had this lot of analysis done with this tool. Can we go to the next one? Only 2 more slides I have. This is another key important thing for us, is to identify where people live so that we can do the service delivery. There was a famous saying that if you do not exist in a map, it means you do not exist for your services. Because for polio campaign, for example, it is as simple as giving 2 drops of vaccine to a child. It means a vaccinator has to go and reach the household and give the vaccination, 2 drops of polio vaccines. But if they are not aware of where the settlements are, where the population are growing, it becomes very difficult for us to serve that community. That's why getting high resolution satellite imagery, doing a building footprint, identifying where people live, then aggregating that into bubbles and making sure that somebody is reaching every tiny bit of this place so that we are doing our job. So this is a very important tool for us. Next one, please, Prashant. The whole thing sums up into this on microplan. I talk about this in many places. There's only 5 things which is very critical for us to do our operations in the field. One is the base satellite image. The next one is where people live. The third one is the location of health facility. The fourth one is a catchment for each of the health facility. And the fifth one is the travel time. This sums up all our work in the field for all the immunization activity, for disease surveillance to support outbreak response. This is the basic nutshell what we need, and this is how we operate. Thanks, Prashant. Next. Finally, the whole, I think Prashant mentioned in the start, is like we have a team close to 50 people now. They're based in 20 different countries, anytime ready to be deployed to the field. And these are the people who are behind the show, who are making it possible. I stop here. I let the floor back to Inga and Prashant. Over to you guys.
Okay, as you mentioned earlier, we have an amazing set of speakers today, and we would like to thank them for joining here. And so we'll start with Stefano. And Stefano, are you able to share your screen?
Yeah, just a second.
And then
No,
after you,
I think I'm getting a message that I cannot share while another participant is sharing.
okay, I can unshare my screen, but I just wanted to see everybody's aware of the sequence. After you, it'll be Jojo Mehra, and then Cyrus Reginald, and then followed by Nandini, and then finally Jayanti Shastri would be the different speakers. So let me unshare my screen. Okay, go ahead.
Can you see my screen?
Not right now. We were seeing your screen before.
Just a sec.
It came on for a little bit, and then
No. We have it again.
Okay. Now. Okay. Can you see my slides now?
Not yet.
It's not coming.
we are seeing your Zoom screen.
Yeah. Maybe you should share the full screen instead of just a window. Maybe it would be easier.
Okay. So you're seeing my Zoom screen, right? Sophia.
For a short time, your PowerPoint screen came
Yes,
on.
we were
and
just seeing
then-
your slides 2 seconds ago. Yes.
Okay, so let's try again. Can you
Are you
see now the
using-
Yeah.
PowerPoint?
Yes,
Okay, I put it full screen then.
yes.
Perfect.
Like it.
Okay, great.
Here we have it. Perfect.
Thanks. So thanks for inviting us here from the European Space Agency, and I'm pleased to present the Earth observation for health activities, and in particular with a focus on the collaboration between the European Space Agency and India. So our vision is to take the pulse of the planet. As you see here, we have many sensors placed on our satellites that can monitor ice, water, land, atmosphere, and we do that in two ways. One way is through the Copernicus program funded by the European Union with us, where we basically monitor policies. You see here 6 missions that are already operational and another 6 that will become operational very soon. So we will have 12 operational missions providing open, free, and full data anywhere in the world, and with continuous coverage. We also have other satellites called Earth Explorers. You see here the list of them. And these are science missions. So they are very specific, and they are developed to address different fields of science. For example, carbon cycle, photosynthesis, greenhouse effects, clouds, aerosols, or winds, magnetic fields, water cycle. Where do we link with space? So first of all, we are part as observers of the United Nations committees. So we've participated in the definition of the Agenda 2030 and the associated Sustainable Development Goals. So we develop projects called Space for Sustainable Development. The second area is on disasters. So we are active towards in the context of the Sendai Framework for Disaster Risk Reduction. And we are members of the International Charter of Space and Major Disasters. And the third area is on climate change. So we provide data via our climate office towards more than 50% of the essential climate variables that in fact can be monitored only from space. In terms of collaborations, we work with UN-USA, WHO, UNEP, FAO, and WOA in the quadripartite context. We also work with the European agencies dealing with health, and with some national health institutes in Europe. We collaborate with JAXA and NASA and with ISRO. So here it comes the first collaboration with India. It's on exchange of data, mission definition, satellite mission definition, and capacity building. We also have some projects, and Nandini Menon will go more into the details later, in the Lake Vemabad in Kerala. And we have signed a collaboration agreement between India and ESA called the COBRA Initiative on the development of Earth observation applications. You see also that we are working with 3 institutes in India: the National Institute of Oceanography, the CMFRI, and the NERSI. We are also establishing dialogue with NGOs, GEO, Nereus, MSF, some of them also with dedicated projects in India. And we have also defined a strategic innovation partnership with GDHub as well in Geneva. And as part of that, we are members of the Space and Global Health Network, where we have just last weekend organized a joint hackathon on space and health. And also we develop capacity building activities together on like training, curriculum on space and global health, and so on. We are also planning next year, early next year, the new User Forum 2025 that this time will be hosted by WOA as the Secretariat of the Quadripartite on One Health in Paris. We have also sponsored and contributed to the organization of the Space and Global Health Conference in Geneva last November. We had this EO for Health User Forum 24, where also Indian representatives were participating in January this year. And we've been addressing waterborne diseases, vector-borne diseases, and non-communicable diseases. You see here the intersection between Earth observation and One Health. In particular, we are with FAO, WOA, and EFSA, we are working on epidemiology data sets for example, West Nile virus or Rift Valley fever. On the blue environment, waterborne diseases, we're working on E. coli and cholera, in particular with WHO, ECDC, and the European Environmental Agency. In this domain, we have also last year delivered the training for 6 months every week on satellite-based tools for investigating aquatic ecosystems with a specific focus on waterborne diseases and use cases in India. This is the recent hackathon that just took place last weekend in Geneva. And this is our roadmap. You see here how many projects we had since 2019. And one is still running. In fact, we just expanded this project called the WIDGION, Waterborne Infectious Diseases and Global Earth Observation in the Near Shore, also to Indian stakeholders and Brazilian stakeholders. And here you see what we are doing in Kerala. So combining waterborne disease, basically cholera data sets with Earth observation, with the idea to predict outbreaks using also artificial intelligence, monitoring ocean color, temperature, and precipitation. And on the right side, you see the Earth observation dashboards that were prepared in the context of the COVID-19 pandemic, and that they are further developed together with JAXA and NASA. A little bit on the WIDGION collaboration with India. So you see here how many partners are involved. We are identifying and characterizing the recreational beaches with in situ observations of pathogens and the external environmental conditions. Nandini will probably also present a smartphone app for sanitation surveys to study the relationship between sanitation and disease occurrence. And we are combining disease database with Earth observation and model data to develop a model that can predict, in fact, these disease outbreaks. You see here the relation with floodings, in particular the link with septic tanks and flooding, and then let's say clean water provision to the inhabitants. We have been doing this using Sentinel-2 and Sentinel-1 satellites of the Copernicus constellation I introduced at the beginning of the presentation. And you see on the right also how these measurements relates to flooding and E. coli distribution and abundance, in addition to the cholera studies we are doing. As I mentioned, we are also strengthening ties with NGOs, in particular Médecins Sans Frontières and SOS Children Villages, to co-design sustainable solutions and also to empower local populations in the health domain and having the space sector involved at large. And this is a very good pilot project, the one we have in India with NGOs and schools, for example. We are part of the Space and Global Health Network, as I mentioned. This is under the umbrella of the United Nations General Assembly Resolution on Space and Global Health. We kicked off in April this year the curriculum on health and space task force. So we are now designing this curriculum, and any input from representatives of India to this will be highly valued and appreciated. This task force is led by the GD Hub, based in Geneva, and ESA is a member of that. And then the idea is also then to have a direct link, a continuous link with the UN COPUOS Scientific and Technical Subcommittee. So basically every February to report on these developments to all the United Nations members that are gathering in Vienna at this committee. And this is all managed under the United Nations Office of Outer Space Affairs. And also WHO is, of course, collaborating and contributing to this activity. So if you want to discover more, this is our website and our social media. So thank you for your attention, and Ravi, back to you. Thanks. Ravi, Inge, Sophia, back to you.
Hello. My apologies. I was speaking and I was on mute. I didn't realize that. Thanks, Stefano, for your wonderful presentation. And I hope you're able to stay until end of the session so we can have a panel discussion and some Q&As. Can I ask Jojo to go ahead and make his presentation on Digit and health campaign management? Jojo, can you go ahead and share your screen?
Sure, Prashant, I'll do that. Thanks a lot. That was a great presentation, Stefano. I look forward to our discussion. Meanwhile, Prashant, if you could confirm if my screen is visible, I'll just share my screen.
It's okay, it's coming. Yeah, we can see your screen now. And we can see your full screen now. Go ahead.
Thanks a lot. Hi, my name is Jojo Mehra. I'm the Chief Product Officer at eGov. It's good to be here at this session. I'm going to speak about the work that we're doing in public health and largely focusing on Digit health campaign management. That's a product that that we're using across multiple diseases, multiple health campaigns. First, just a quick note on eGov. So eGov is a not-for-profit organization. It's a 20-year-old organization based in Bangalore. We build digital public infrastructure. We work with governments and we work with markets to transform governance and public service delivery. So there are three key pillars of our work. One is we build the platform and digital public infrastructure. We help enhance the capacity of the network, and we help catalyze market participation. There are four key areas of our work. We work across the urban space, we work across sanitation, we work across public health and public finance management. And the same platform is also used across multiple different use cases through our partners. So far, we've helped the governments deliver about over 1 billion public services. We've helped mobilize revenues of over 2.1 billion, including some work that eGov did in COVID, which is in the distribution of the COVID vaccination certificates. So till date, about 2.3 billion COVID vaccination certificates were printed and delivered. The work has touched about 260 million citizens, and we work with a network of over 200 partners. It's supported philanthropically through the Nandan Nilekani Philanthropies, Omidyar Network, Tata Trust, the Bill and Melinda Gates Foundation, and the Global Fund. So I'm going to spend about 30 seconds on the 3 key pillars that we spoke about. One was on building the digital public infrastructure. Here, essentially, we build the platform, we build products and solutions. There are reference applications, and there are open APIs and specs that help governments and multiple program partners to leverage these to deliver their programs. We help catalyze market participation, and we do this through the Digital Academy, which is our training academy. We've published a few thousand playbooks and toolkits, and we help generate demand for market participation as well. And finally, we work very actively with government partners, with program partners in reimagining how you can use digital technologies for better outcomes. We work with policy and strategy, and we provide advisory and governance services. Today, I'm just going to focus on one part of it, which is on our work in public health. And very quickly, just I won't belabor on this subject. I'm guessing the audience over here is very well aware. Our work on Digit through health campaign management, which is the product, focuses on, so when we start trying to understand the problem, we looked at it from 2 perspectives. One is the people who are actually using these applications, using these tools, and how can it be relevant to them. The key problems that we saw was about having very little availability of information when it came to national agencies. When we looked at supervisors, we found that whether it's the warehouse supervisors, program managers, people on the ground are constantly firefighting with very limited information and limited resources. And for frontline workers, we saw that there were repetitive tasks, there were issues of payments, etc. Overall, when we looked at this entire thing as a system, when we looked at health campaign management, what we saw was that there was very low campaign effectiveness. Logistically, it was extremely complex. Again, there was limited visibility of data and information across different actors in the entire system. Most of the work that we saw, even where there were digital tools being used, the approach was very siloed. And when we spoke to governments and departments, what we understood from them was that there's very little ownership of their own data and their digital assets. When we looked at data again, so sorry, are you saying something, Krishnan?
No, I think
it was some
someone
other
else.
disturbance.
No problem, no problem.
Okay, I'll carry on. Right. So when we were looking at countries and trying to understand the role of digital in this, what we found was even when digital technologies are being applied, the approach essentially was duplicative. There were multiple systems, multiple applications. The data was locked in silos. While systems existed, the systems did not talk to each other, which made all the digital initiatives extremely hard to scale and even more difficult to sustain. And finally, like I said, one key element that came out from by talking to governments was that there's very little ownership of their own data and digital assets. I'm going to spend a minute on this slide, and this is really key, is saying when we talk about digital technologies and we talk about digital systems, there is an approach that is currently being followed that's largely followed across multiple different programs. This is representative here. So to the left of my screen, where you have, let's say, a polio program, you have a malaria program, you have measles programs, and they all are running their own campaigns. Now, when they're running these programs, there are multiple interventions and use cases that need to be adhered to. Right, so you need some kind of a digital system or a tool to help you plan better, to help you get registrations better, to help you track your inventory, to look at your dashboards, to look at the delivery of things. And ultimately, what ends up happening is there is a need to get these systems to talk to each other, and then you start looking at a point-to-point integration. And the same process is then repeated for the next program. Overall, what ends up happening is that it becomes your entire system generates the spaghetti code, and it becomes very hard to make any sense of the data, right? The amount of effort that you spend in trying to harmonize the data and draw any insights is sometimes it takes months just to arrive at your insights from a campaign that ran for a month. The platform approach looks at it slightly differently. It basically says that, hey, let's understand this whole idea of registries where we can have data between, let's say if it's your user data, your location data, your facility data as common registries that can be used by multiple programs. When it comes to building out applications, we're saying that whether you're building out a registration application, an inventory application, or a warehousing application, etc., your core services are essentially the same. So can we look at a system where you're not rebuilding things and you can use it off the same platform? And then finally, when you're using these for different programs, essentially, can you look at configuring the same capabilities for different use cases rather than reinventing the wheel over and over again? So looking at 4 key building blocks over here, what we're saying is, can you have reusable building blocks to build multiple applications so that one product can be repurposed for all sorts of campaigns, all sorts of diseases? Can we have shared data registries so that you capture the data once, it's enumerated once, and then enriched continuously each time you go out on the field for different campaigns? Can you have interoperability through open APIs so that your data flows across systems, your solutions start to interoperate? Can you use the same building blocks to extend or create new solutions? And can you lower the cost of software and running programs where sovereigns can own and evolve their own digital assets, right? So this is the promise that we made when we started thinking about Digit HCM as a product. Overall, I'll give you a very quick overview of what the Digit HCM does, right? So it's very quick to set up. It helps you plan better. It helps you streamline your operations, everything from your help desk to your complaints to trainings to inventory to payments, etc. It simplifies your delivery all the way from registrations to service delivery to do a check-in, in-app job aids, etc., and helps you go and monitor in real time. While creating this, it took us a good few months to create, and we created this with people who actually run campaigns. So the team spent about, I don't have that over here on the slide for paucity of time, but the team spent about 100 days on the field in multiple countries in Africa, in Mozambique, in Liberia, in Nigeria, etc., to try and understand and shadow actual campaigns. We work with these knowledge partners and our funders. Overall, the Digit has already been used in Mozambique and Liberia, and is right now being planned for a rollout in Mozambique, Liberia, Nigeria, Burundi, and Senegal. The one thing that we understood was the importance of having good design that leads to better adoption and hence better outcomes. One of the common things that we heard from frontline workers, from supervisors, from admins, is saying that it's really simple to use. I have a video here, but for paucity of time, I'm going to skip that. Right now, we have strong interest coming into 15 countries in Africa who are keen to use Digit HCM for different campaigns. Like I said, it's already been used for malaria, for BedNet and SMC. It's going to be used for IRS. It's already being looked at for entities and polio, and we have interest from Nepal coming in from for TB. This is how we're seeing the entire landscape in Africa, where we're seeing strong adoption again coming up for Digit HCM. We work largely with partners, which is market partners and program partners, and we have a core scale partners that help us understand the domain. We started off in malaria, but the way it's designed is that it can be used for multiple types of diseases. Because this conversation is largely focused around GIS, the next challenges that we're looking at is saying, how do we leverage GIS to get to better population denominators, missettlements, and lack of access? So these are the 3 key problems that we're working on immediately. In fact, we're talking to the WHO is going to advise us, is helping us in this. The way we've looked at these problems from a campaign perspective is looking at how do we get your missettlements, how do we get to better population denominator? Can we look at lack of access? How do we work on lack of time? How can we get better operation or oversight? And there is a strong issue of inaccurate or fake data that is there in campaigns, and how can we use GIS to go and address some of these? Right. I'm not going to belabor this point. This is largely this audience would understand, but I just return on some slides on saying, hey, how do we look at how can GIS really help you understand, find out your missettlements? Can you get to better population denominators, especially when your boundaries, etc., keep changing? And can you look at access when it comes to delivering health campaign resources? Overall, what we're looking at is, so this is the view of our roadmap. Right now, in the current deployments where Digit HCM has been used, we are somewhere between, let's say, step number 1 and 2, where we're looking at immediate campaign improvements that helps, where they can very quickly go and set up. They can have real-time data through your dashboards. It helps get operational efficiency almost from day 1. It definitely lowers the cost of campaigns, and it can be used for multiple diseases. But as time progresses, because of the way it is constructed, because of using the common registries and having data interoperate with each other, we're looking at, can we have campaign transformation where you can start redesigning your campaigns itself and start using historical data, to inform what's going well, what's not going well. And finally, can become a key component, a key building block towards your digital public infrastructure for health. With that, I'm going to stop. I think I'm on time. There is a video which I'll be very happy to share after the call on chat. Over to you, Sophia. Back to you.
Thanks, Jojo, for the presentation. I can see that there's a lot of commonalities, and I think this will. I hope we can at the end of this we can have more overlaps, and how do we work with each other, because I saw that you also look at population using satellite imageries, and also so let's go ahead with the next speaker now. Cyrus, welcome to the workshop, and can you go ahead and share a screen? Cyrus is going to speak about his work on program called Kushi Baby, which means happy baby, and the work they're doing in Rajasthan. Go ahead, Cyrus.
Thank you so much. Yeah, let me just quickly share my screen. Yeah. Hope everybody can see my screen.
Yes, go ahead.
Perfectly.
All right, thank you. Yeah, first of all, thank you for having me here and for giving the opportunity to present Kushi Baby's work. As it was just mentioned, Kushi Baby means happy baby, and given the origins of the organization was child and maternal health. So let me quickly introduce myself. I'm Cyrus Reginald. I'm actually a part of Poverty Action Lab, JPAL South Asia. I'm currently doing a fellowship with Kushi Baby, where I'm assisting them at the intersection of climate and public health, where I build a few predictive models, but also some descriptive work, hopefully, which will help address the health risks arising out of climate change. So I'll quickly define and kind of take you through what Kushi Baby does. It's primarily a digital health platform. Given that the focus of this workshop and my presentation is mostly on the GIS work we've done in the past, I'll just keep that to just a couple of slides and a very high-level overview. And then I'll probably describe some of the GIS work we've done and what I'm currently working on, and also a bit of background on the thinking we have around GIS and why we feel it's important. So I'll just start with what Kushi Baby's focus areas are. So as you can see, the primary focus area has always been child and maternal health. And this is what Kushi Baby started working with the government of Rajasthan for. And currently they are the technical partners of the Rajasthan government's Directorate of Medical and Health Services. And the current mandate is not limited to maternal and child health, but also to NCDs and other communicable diseases, as well as periodic screenings, surveys, etc. So that's a quick overview on the priorities of the Kushi Baby platform. I'll next go into how the platform works and how the data is collected and what we do with the data. So the Kushi Baby, as I said, is an organization, but primarily a digital health platform. They have multiple applications for the auxiliary nurse and midwife, the ASHA, who's the community health worker, and also doctors at the PHC, the primary healthcare center level, where they can track a particular individual as they interact with different levels of the primary healthcare ecosystem. This can either be a digital health census, which is done at a door-to-door level. This can also be just follow-ups, community surveillance, or when they reach out for regular treatment. Also, and mostly primarily when they reach out during pregnancies and after pregnancies in the early childhood phase, where the platform tries to track the health of the baby and as well as the mother during that period. And the platform also is linked to ABA and the smart health card as various points of identification. And as you can see, it covers around 30,000 daily active entries from community health workers, a total population of around 45 million reached. And some of the analysis work has also led to identify a lot of high-risk cases for different health outcomes, not just pregnancy-related or early childhood health outcomes. And what happens with this data? There is a chip dashboard or a community health integrated platform, which Kushi Baby has built. And this can be accessed at varying levels, at the state level, at the district level, and the block level. And I think this would be a good segue into the GIS work. So what I've described so far is just a very high-level basic picture of what Kushi Baby does. And I will just move on to the GIS work. So as you can see on the screen right now, you can see a map with a bunch of visualizations. This is one of the views in the dashboard, and the dashboard does, in addition to having a visualized view, also gives you tabular data and customizable filters, etc., which can be used at the different levels I just described. Yeah, this is another example of GIS-based visualization, which we have with us. It is also available on the dashboard, and you can layer multiple views on top of this. And you can say at which level it wants to define this multidimensional poverty index. And this again is based on data which is collected by the community health worker during those digital health surveys, and the census which I described a few slides ago. And again, just a couple of examples of the GIS visualizations which Kushi Baby has done and provides on the dashboard. One was mostly on health parameters. This is more on the socioeconomic side. I will now move on to why we believe GIS analysis is important and why we feel it's something which we need to do rather than just provide tabular data and call it a day at that. What we've come to understand is that, of course, we can correlate health outcomes to individual socioeconomic factors or n number of variables which are causing these adverse health outcomes at the individual level. But when it comes to policy action from the side of the government or any non-governmental partner as well, it is still bundled at the geographical unit, which means if an intervention is to be done, it's usually done throughout the block or throughout the community or throughout the district. So it is good to try and understand what adverse outcomes are there, what is the density of these adverse outcomes, what is the population which we need to address, and this makes it worthwhile to try and analyze outcomes and different variables at different geographical units and not just at an individual level where you can relate it to different socioeconomic and other related health outcomes of a particular individual. And we also believe in some cases, the geography itself could be causing disease prevalence or outcome. The primary example is climate change and climate in general. Of course, you can try and feed in, you can still do the analysis at the individual level, and you can feed in the environmental variables for each individual to say, okay, this person lives in a village, so this must be the temperature, this must be the pollution, etc. But sometimes we might not have that level of granular data. So at least at a first pass of the analysis, it's good to work on with a geographical unit to see the prevalence. And then if we see clustering around certain geographical units, then dive into what factors within that geography are causing certain outcomes. And lastly, why GIS we feel is important is visualization conveys the message much faster. In my opinion, to two very different category of viewers or consumers of this data. One, somebody who's very new to the geography and the domain of the data which we are trying to show. Instead of just showing a barrage of an essay or a big table of data, it's usually easier to get your first understanding through a map where you can quickly try and get a high level view of what is the message which the data is conveying. And also the second category of consumers of data for whom visualization makes a lot of sense is somebody who is very oriented and has a very deep knowledge of that domain and of that geography. So this individual already probably has a mental map of that particular geography and of that particular domain which we are talking about. So if you just provide a map instead of a table, the message, they just overlay that map in their head on top of whatever map they already have, and it gets the message across much quicker. It's just in between these categories, there are individuals and consumers who are looking for granular data, but like on different specific niches. For them, maybe tabular data or descriptive data makes more sense. And of course, the GIS analysis is not without its challenges. The primary of those is sometimes visualization is great, you show it, but then how do you translate that into policy action? That's a gap. Sometimes it's obvious, sometimes it's not. So that's something which we find as the primary drawback of any GIS analysis. And second, the uptake, which is from our observation with our government partners, is the uptake is still quite low, especially at the slightly granular level, where they're just looking for tabular data to complete their data reporting needs and not really concerned about visualizations and trying to understand the data in detail. I'll move on to the climate vulnerability index, which is primarily what I've been working on. What we are trying to do is to define and classify different geographic units based on their vulnerability to extreme climate or climate change. So what we do is we look at different exposure variables, which are primarily climate-related variables. We look at also sensitivity variables, which are mostly health outcomes. And we also look at adaptive capacity. What is the prevalence of poverty within that geographical unit? And also what is the availability of health services, public health services, as well as private, and then come up with a consolidated index to say at this district is at high risk to the effects of climate or climate change. And what we've done is we've created an index for each month of the year, given that climate is cyclical and varies within the year. That is a first level broad analysis. And as I said, to somebody who doesn't have much of a context, it's a good first view. The next step, what we are currently trying to do is to go more granular. We have at the district and block level, we'd like to go more into the village and community level. and try and identify vulnerable populations as a whole. And also, we would also like to map vulnerability to different sensitivity variables. Because bundling all of them is a very simplistic and naive approach. It's good to start off with, but then we want to figure out the different predictive powers that climate variables have on each of these sensitivity variables, so that this can then be translated into policy, and hopefully some of the adverse outcomes can be addressed before they happen. So this is just, again, just to give a quick visual representation of how the vulnerability index looks over a year. The one on the right is at the district level, one on the left is at the block level. So this is where we are currently at. And as I said, we hope to go more granular and look at specific variables as we go along in the next few months. And that's all I have. And thank you for having me here, as I said, and looking forward to hearing what the other presenters have to show and to discuss with all of you after that.
Thanks, Cyrus. That was very insightful. We also look forward to having some good question answers for you, and what your data sources were and how was your data. How challenging it was. So let's keep those questions for a little bit towards the end. Without any delay, let me call Nandini. You want to share your screen and start your presentation?
Yeah, thank you. Thank you, Dr. Prashant.
Yes, we can see your screen. Yes, we can see your screen.
Okay. Okay. So good morning, everyone. Good afternoon. Good evening. Yeah, wherever we are. Okay. So I'll be speaking on the geospatial applications for public health in India from an environmental perspective, and pretty much of it has been introduced to you by Stefano. It's teamwork. Our team, which has been, we have been working on this aspect because we are all basically oceanographers or related to marine environment. So from our area of expertise, we are looking into the public health domain. And to start with, we all know about the role of environment in influencing the conditions under which pathogens spread and cause harm. And this environmental conditions, and as far as waterborne diseases, that's the area where we are focused on. As far as waterborne diseases are concerned, we understand that environmental variables have a definite role in determining whether a microbe present in the environment turns to be a pathogen, and depending upon the conditions prevailing, or also whether it becomes serious enough to, sorry, I cannot see my slide. Yeah, sorry about that. Whether it's able to bring about a disease outbreak. And presence of a pathogen just in the water body doesn't cause any disease outbreak. It also depends upon the exposure conditions of the populations, the vulnerability of the population to the their exposure to the pathogens, which causes disease outbreaks. So our attempts have been to reduce these risks. That is how the pathogen abundance in the environment can be controlled, and also how the exposure conditions can be improved. So as a first step, what we did was that we identified linkages between the, we identified links between the environmental conditions and also the pathogenic, Are you able to see my slide now?
Yes.
Yes, we can see it.
We can.
Okay. So our first step was to identify links between the environmental variables and disease outbreaks via the environmental burden of pathogens. And you would have seen this figure from Stefano's presentation, that is, which happens in the southwest coast of India, that's in our state, Kerala, where the coastal areas as well as the banks of the lake, it gets flooded during times of heavy rains and floods, which results in a breakdown of in sanitation conditions, leakage of sewage and mixing of sewage waste with the water, contaminating the entire source of water, whether it is for drinking or for other recreational or other household purposes. And our in situ data collection, that is the, we have been able to establish a relationship between E. coli in water and rainfall, how they vary with the amount of rainfall in the area. Another result, another example is that between flood and the leptospirosis outbreak. If you think about the bacteria Leptospira, which causes leptospirosis or rat fever, we find that the incidence of Leptospira bacteria in the area is at its peak during winter season. Whereas if you look at the incidence of disease, this is the in situ data that we have collected as part of our India-UK revival project for 2 years, which we found that the incidence of diseases were more during time when floods occurred or during rainy seasons. And many of you would remember that Kerala faced the century's largest deluge in 2018 when the entire state was flooded. And this, not only the flood, but also the amount of the duration up to which the flood water remains in the environment, that also has an influence on the incidence of diseases. So highest incidence is reported when people are forced to interact with contaminated water. Then, not only from our area, but we also have examples from around the world, that is climate change events like El Nino. Martinez Urtaza study in 2018 has shown that the El Nino event it serves as an ocean corridor between Asia and South America for the transfer of Vibrio bacteria. And the major Vibrio outbreaks in South America have coincided with the El Nino events. So what do this show? That is understanding the role of environment in disease outbreaks. This can help us to improve tools or to design tools for monitoring, containing, and even preventing outbreaks. And for that, this relationship which we have built with variables, the environmental variables, we have used this relation to make risk maps, vulnerability risk maps for many of the for the diseases, cholera, as well as for leptospirosis. And this is one of our first projects, that is the India-UK revival project, in which we did in situ sampling of the water, and we found that the chlorophyll data which we obtained from in situ sampling matched well with the satellite data, and then we established a correlation between satellite chlorophyll and Vibrio cholerae occurrence in the water. And it was found that in the Vembanad Lake, which Stefano mentioned, this our study area or our model ecosystem, it has a brackish water as well as a freshwater component, and it exhibits both positive as well as negative relation. So it's not only the chlorophyll, but also the salinity, the phytoplankton composition, all of which has an influence on the presence of or the abundance of Vibrio cholerae. Based on this, we were able to, we successfully made a risk map of environmental Vibrio cholerae incidence in lake. And it was found that the areas where we found largest number of Vibrio cholerae in the environment, those areas had the largest number of disease outbreaks as well. Then the next thing was floods. That is, after 2018 state of Kerala, we are having regular floods, and also not only floods, but the water remains. The residence time of water is much more. So for that also, and in most of our studies, what we have used is, we have used Earth observation data, satellite data of high resolution. Stefano has already shown you about the Sentinel satellites, which give you high resolution data, and not only high resolution data, but also they provide us an optic view of the environment. So using the Sentinel-2 multispectral and Sentinel-1 SAR data, we were able to come up with a water index algorithm. But then the state of Kerala, or the Vembanad Lake region, is peculiar in that we have a below seawater level paddy cultivation. So some areas are permanently flooded, or it appears to be flooded to the satellite. And so we did simultaneous in situ monitoring as well, and established a water index threshold and made a permanent water body map of the Vembanad Lake, and thus were able to map floods. These flood prone areas are also the areas which are prone to disease outbreaks. This is the recent paper by Gemma and all of us. Then the next menace is invasive weeds, floating vegetation. This also we have done as part of the ESA funded Vision project, in which, that is, these floating vegetation, they act as or they harbor large amounts of microbes, as well as they harbor vectors, resulting in outbreaks of vector and waterborne diseases. And during rainy season, the entire lake gets filled with these floating algae. And we use the algorithm by WHO and replaced it with the Sentinel wavelengths, that is near to the wavelengths that were used by WHO from Sentinel-2. And we were able to get good matchups. That is, we did simultaneous field validation as well to better the algorithm, and we came up with floating vegetation index. And this work is being done by Emma Sullivan from PML and Ranit from our institute. And it need not be EO data or satellite data always, because citizens are the main stakeholders, and you can leverage citizens to collect data. And here we came up with simple gadgets. That is, it's a 3D printed mini Seki disk. Seki disk is the simplest device which can give you an estimation of water quality, both color as well as clarity. This Seki disk is actually pasted with a Forel color scale, so you get the color of the water as well. And we also built a mobile application to store the data, and whichever data the citizen enters in the mobile application, we'll receive it in our server. And this is the amount of data which we collected. The red one indicates the scientific measurements done by us, and the yellow are the citizen science data. And from the Forel color scale, we were able to build a map of the estuarine water usage, whether it's an industrial area, barmouth region, fishery, and this watercolor matched very well with the water usage of this Vembanad Lake. And we have a citizen science network established in Kerala with college students as well as local people or stakeholders. Then another was the statistical analysis, that is geographical clustering done to identify the relative risk assessment using the spatial data of diseases available. We establish the disease outbreak per 1 lakh population, 100,000 population, and also using a Poisson model regression, we built relative risk. That is using the geographical coordinates, time, that is from 1995 to 2021, and also the disease reports. Then we found that that is, the Poisson distribution gives you an indication whether if almost 2/3 of the points fall with or have the same relative risk, they come as a cluster. And if you have a cluster, we found that the disease spread as well as occurrence of disease in this cluster is related, and it spreads faster than the remaining clusters. And we found 4 clusters in the state of Kerala using the disease data, and clusters with high relative risk were prone to disease outbreaks more than the regions where we had lower clusters, lower relative risk value. And this clustering analysis actually led us to another finding, that is socioeconomic or social conditions have a great influence on the exposure to vulnerable situations and also to disease outbreaks. And we found that many of the key determinants of health and the causes of infectious diseases lie outside the direct control of the health sector. So using some of the indices, that is whether you have the number of houses in the rural area, practice of open defecation, what is the source of water the people use for drinking or for other purposes, and if the source of water is away from their house or in the household itself, and building relationship with total cholera cases, we found that they were all statistically significant. So they also have a very close relationship with the disease outbreaks, the social conditions. So in conjunction with the along with the environmental data that we collect and the relationship we build with the diseases, we found that sanitation data is also much important for assessing the vulnerability to diseases. So with this, you remember Stefano mentioning about the sanitation app Cleanse. This is the app which is launched in Google Play Store, built as part of ESA Vision project, which gives you a set of questions. And at the end of it, it gives you a score, whether your environment or whether your area is vulnerable to disease occurrences or not. It's a bilingual one in English as well as in the local language, Malayalam. And this is actually using just 130 points, which using that, we built a map, that is susceptibility map, and we found that this were in the safer locations. So you have a low vulnerability to disease occurrence, waterborne disease occurrences. Then, most important, following John Snow's footsteps. That is John Snow, the physician who did work on cholera and identified that cholera is related to, or incidences of cholera is mainly due to contaminated water from pipe, and he closed all those, or he actually mapped all those things. We also have a mapathon approach, and our young colleague Dhriti Sengupta, who is also, this is also part of the ESA funded Vision project. He is in charge of this, and we already did 3 workshops in Kerala, mapathon workshops, training college students, and that is mapping the land use pattern. Usually mapathons are used for mobilizing resources at times of emergencies, but we use this to get data on sources and pathways of water contamination and its impact on health. And these are some of the indices that we use, or that we have trained the students to map. And all these attempts are done because we value the importance of data and the quality of data. And quality of any analysis depends on the quality of the data. And we know that COVID-19 is the good example of problems associated with undersampling. And in the case of diseases, problem is much higher than COVID. COVID was a pandemic, but in many of the other diseases which go unnoticed, it is much higher. And data quality issues tend to be worse in low-income countries, where you have more prevalence of these diseases. also the waterborne disease burden is very high in those areas. And this is just an example to show you how difficult it is to analyze when the data varies with sources. We have been relying on satellite data and the Copernicus data mainly because of the quality of the data that they give. But coming to the disease data, this is an example of 2 districts in Kerala. The diseases mapped are acute diarrheal disease, leptospirosis, and cholera from 2 sources. We get data from Department of Health Service, Kerala government, and we have a national portal, Indian Disease Surveillance Portal. Just see the difference in the number of diseases recorded. I understand that it's a politicized issue or it's something that has to be done, but data quality has to be assured. And at this moment, I agree with Jojo when he say that we have poor data and also the quality of data, the way in which the data is presented in the portal. These are all very difficult to decipher and bring it to an analytical platform. And another thing is, again, quoting Jojo's words, we are all working in silos. So we have an open network for water-related diseases. We have built a global network of interested scientists, not only scientists, but also laymen to learn from each other and also promote collaborations to fill in the knowledge gaps we have on waterborne diseases. Then, and in this, in addition to network, we also have a strong capacity building component where we organize webinars, training programs, both online as well as in person, practical training as well, for people around the world. And I can proudly say that we have a member strength of almost 450 people, 450 scientists from 48 different countries, not only scientists, but young researchers as well. And conclude. We find that EO data can generate information and products that can significantly improve the scientific knowledge of existing public health. And it's not only from a medical point of view, but we have to move on to a One Health, not One Health, but One Planet approach. And geospatial data actually helps us a lot in enhancing our understanding of the ecosystem dynamics, and it becomes extremely useful in case of extreme weather events of climate change and their influence of human health. But what we need is that we need time series data. Time series data is very essential in case of strategic actions associated with health and for climate change issues. The problem is very complex and we need to have an integrated multidisciplinary approach. Another thing is need for more data. That is, data sharing is very important, and both clinical as well as environmental data. And what we found is, or what we find is, community engagement is key, and citizen science is an important avenue to the solution. And the problem is not local or regional or to Vembanar Lake or coastal areas of Kerala, it is global. With that, I conclude. And this all dedications to Professor Trevor Platt, the great visionary who actually led us into this work. We are doing the 5th project in the series, and he continues to inspire us. Thank you.
Thank you, Nandini. That was a very elaborate presentation. I'm sure because of the overlap we'll have.
Did I overdo the time?
That's okay.
Sorry.
That's okay, no problem. Yeah. Dr. Jayanti, you want to go ahead and share your screen and go ahead with your presentation? Yes, we can see your screen.
unmute, then share.
We had your screen, now it's gone.
Yeah.
Oh,
So
it's
hello,
coming up.
everyone. I'm also learning from all your presentations, and thank you, Dr. Prashant and the other organizers for giving me this opportunity. Well, this is a real life situation which I'm going to share with you. And it is only pertaining to leptospirosis, though in Mumbai, we do see a lot of infectious diseases, vector-borne, waterborne. And here we, in this presentation, I will share our One Health approach towards identifying the source of leptospirosis. I'm Dr. Jayanti Shastri, who's a professor at the Center of Excellence in Research and Training in Infectious Diseases at the Maharashtra University of Health Sciences. I come with 4 decades of experience in infectious disease diagnostics with special reference to the molecular diagnostics. So I'm not able to move my slide. Why am I not able to move my slide?
You can just click on the slide. See.
Oh, yes. So we do see a lot of leptospirosis in Mumbai. So we've been detecting this disease by molecular diagnosis, that is PCR, from 2007. We do have certain years when we have more number of cases, but more so only in the monsoon times. And in 2015, in fact, we did have an outbreak of leptospirosis. Like, as we all know, a definition of an outbreak is an occurrence of a disease in excess of normal in a defined community, geographical area, or season. So this is what we saw. And come monsoon, and our labs are all very, very busy with diagnosing these infectious diseases. So heavy rains and another 7 to 10 days, we get a lot of cases of leptospirosis. So this was in July 2015. And in a span of 24 hours, I received 283 millimeters of rain. And what we saw was, so this was just from July 1st to, that was June, around 19th, and 1st July to 9th July, we got 15 cases of acute respiratory distress syndrome and 4 cases in August. So 19 patients with symptoms of fever less than 5 days from a specific geographic area and from one hospital in Mumbai, but only 3 gave a history of wading through water and 1 had a contact with an animal. So there was a clinical diagnosis, and I got a call at 9 p.m. that the patients are all dying as soon as they are being admitted, and all the other serology tests are negative. So when we called for the sample for the leptospira PCR test, which is a molecular test to our public health molecular lab, we found that all of them, this is our public health molecular lab at the Kasturba Hospital in Mumbai, and it is state of the art. We have all the automation required for doing early diagnosis. And what we saw was all these 15 samples were PCR positive, and we sent these samples to our regional medical research center, which is at Port Blair, Andaman Islands, for a specific test for leptospirosis, which detects the serovars. And it is very important for us to detect the serovars in leptospirosis because it somehow gives us an idea about the animal reservoir, because some animals harbor certain serovars of the leptospira bacteria. So the MAC tests were asked for, and what we saw was very different from what we had seen in the earlier years. They were very specific serovars of D. jessiman, Bakeri, pyrogen serogroups. which were not reported from Mumbai earlier. So it had all hit the news, and a rapid response team was put together by our public health authorities. And the veterinary college from Nagpur was roped in for animal surveillance in that area. So the highest in command is our municipal commissioner of the Mumbai Municipal Corporation. We had a very high level meeting, and at that high level meeting, the secretary in charge of the animal husbandry department asked the team from the veterinary college to do a surveillance of animals in the area. So blood samples of cattle and dogs were collected. And what we saw was 13 out of 20 cattle were positive for the same serovar. So this is extremely important to complete an epidemiological question as to how did the human infection take place. We are all firefighting in the hospitals. Patients get infected due to environmental reasons or from animals, so like a zoonosis. And most of the times we get very serious infections of humans, and that's what we are most of the time treating. So here we could, and this was the cow shed, which was near the hospital with no separate drainage for urine of animals. So there was very good intersectoral coordination. Our additional municipal commissioner visited the cow sheds, and he requested the owners that, there should be no mixture of any water which is logging because of rains and the urine of the cattle. Thereby, if people wade through this water, they can get infected. However, this issue could not be addressed. And the other major issue which we faced while we were discussing with the veterinary college faculty was transport of animals across states. This is a huge problem because what we had seen, I'll just go to the next slides before the earlier one. So this was the study which was done in the state of Gujarat, where animal surveillance was done, and this particular two serovars were predominant in the animals. And around the same time, there was transport of animals from the state of Gujarat to Mumbai, and these animals were offloaded very near the hospital. So all these reasons, the epidemiological reasons, were enough for us to, have some linkages with the carrier animal. So which are the factors? Factors are a carrier animal, a vehicle of transmission, which is usually a wet environment and water logging, living habits of the population that expose them to these vehicles of transmission. There is a specific host specificity. So that is why it is very important for us to know the serovar. And serovar identification is a very highly technically technical expertise is required to do this test, and that is why we need to send it to the reference center, but it gives us enough clues about the carrier animal. And a change in a predominant animal carrier environment or human behavior change that opens up or closes routes of spread from animals to humans, and that determines the predominant infecting group. So, oh, I think I'm going back. I'm sorry. So we have seen certain animal species across states in India with specific serovars. This mapping has been done by our reference center. And we have seen shifting trends in serovars, which goes to show that the carrier animal is also shifting over the years. So what did we achieve in this whole exercise? Animal surveillance could establish the source of contamination of waterlogged areas due to rain, that is the cattle and dog in that area. Awareness amongst the cowshed owners was very important. about drainage and vaccination of animals. And subsequent to 6th August 2015, we did see a reduction in the cases. So there are some recommendations. We need to increase awareness among private practitioners. We are doing early diagnosis through our state-of-the-art labs in the Public Health Department of the Municipal Corporation of Greater Mumbai. We have made it notifiable to the public health authorities. The private practitioners necessarily have to report leptospirosis outbreaks and cases. The other problem is, of course, we have to regulate transport of animals across states. And MAT is a very good test in order to know the predominant serovars. So regular surveillance, vaccination of animals, strict monitoring of transport of animals, and intersectoral coordination between doctors, veterinarians, animal husbandry department, waste management, environmental scientists. And that is where I met Dr. Prashant and Dr. Nandini when we had this meeting of leptospirosis, where we brought together all the physicians, the veterinarians, the environmental scientists, and we deliberated about what best we can do towards a One Health approach to limit the spread of these infections and thereby reduce morbidity and mortality. Because we know that One Health approach is important, and 6 out of every 10 infectious disease in humans are spread through animals. And very rightly said, Vasudeva Kutumbakam, the earth, one family, one future. Now, I have only one request. There is actually, for us in Mumbai, an urgent need to collaborate. We need to do some amount of GIS mapping of infectious diseases, both vector and waterborne. And I would look forward to any suggestions from all of you. Thank you very much. Thank you.
Thank you, Dr. Jayanti. I had seen this presentation earlier, but again, every time I see this, it's quite a fascinating work that you're doing. And you rightly mentioned the intersectoral collaboration. We have some time for, we are a little out of time, but we could still go ahead and have some questions. And Inga has put one question for Nandini already in the chat, and that's about how did you do the citizen science and what tool you had used. I also have a couple of questions for others, but Nandini, you want to answer that first?
Yeah, I think I typed the answer. No, but then I can always speak. Okay, if time permits. So citizen science, that is, we did a citizen science workshop. We built a network first. That was based on one gadget, because the students, especially the young generation, they like to play with gadgets. And if you have a gadget or a mobile application, it becomes very acceptable. And we have a 3D printed mini Secchi disk. Secchi disk actually measures the color and clarity. And we trained the students. We built designed a mobile application as well. So whenever they enter data, whenever they make a measurement and enter the data, we get the data on our server. And we managed to get almost 1,000 points in 1 to 2 years of time, because students, they easily lose interest. So we need to follow them up. And in 1 to 2 years of time, we got that. But I find that the sanitation app, the other one, Cleanser, which we designed for sanitation assessment or vulnerability assessment, that was the second question based on. First, we did a door-to-door survey to assign, to decide on which all questions to be selected or which are key in determining the sanitation status of population or an area. Then selected 10 questions out of, we made a questionnaire survey based on the UN standards with 35 questions, shortened them to 9 questions. And from the questionnaire survey, we assign weightages to each answer for each question. And based on that, we did a analytical hierarchy analysis and developed an equation. So based on your answer, we get an assessment, a score saying whether your environment is least vulnerable to disease outbreaks, or if it is highly vulnerable, especially places where you have this flooding happening during, regular flooding happening during every high tide, or flooding happens and there is mixing of sewage only during monsoon season, or whether they use boiled water or whether they use lake water, because this Vembanad lake water, we know that it's polluted, it's contaminated, but still the residents use it for cooking rice and use it for washing their vessels and clothes, etc. So all these are given weightages and we give an assessment. And this is found to be more acceptable among the people. So did I answer the question?
Inge, you want to, you have anything to follow?
Thank you, Dr. Nandini. She had actually replied to me in private message as well, but now for the benefit of all, we heard the background. Thank you so much. Very helpful. I think maybe I'll follow up with you for my second question, which was then how that data and that weightage and the score was then used for public health interventions or decision making subsequent to that intervention. So I would be curious to hear more about it. Thank you.
I'll send you the details by mail because I have your mail ID. Okay.
Super. Thank you.
And Jojo, you have put a very nice question there. Intersectoral collaboration, and I want to add to that data sources. Nandini, you touched upon that how data sources can vary. It's from two sources, and that's a challenge. I'm sure, Dr. Jayanti, you're also facing. How do we get our data? Where do we get? And mapping, of course, helps, but so yeah, that is something I think that digital systems does enable collaboration. And Stefano, you want to jump in here, or anybody? Feel free to.
Thank you very much, Prashant. I would say international collaboration is key. We have seen here both at the local level on this specific lake and at global level, where we are even sharing satellite data. We are even planning joint missions and satellite missions for the future with new sensors, where we hope to detect more and more parameters that can help in tackling global health issues. So I would say that all the talks this morning really gave us this local and global perspective, and we are really engaged to continue the collaborations and even to strengthen ties and to include more and more partners that would be interested to work with us.
Stefan, I have a follow-up question on this. Do you also closely work with Indian Space Research Organization, because they also do a lot of lakes level mapping for every month, and they do in Rajasthan, for example, Cyrus, I was wondering if they had done Rajasthan as a pilot study for mapping the health facilities. How do you work closely with ISRO or anybody else there at all, or?
So as I mentioned in my presentation, we signed an agreement with ISRO that is called COBRA. It's on the development of Earth observation applications. And so, yes, indeed, we have this collaborative agreement. And we just kicked off the collaboration a few months back, and we are also planning joint capacity building activities. So indeed, yes, there is this collaboration.
Okay. Go ahead, Nandini.
Yeah, in fact, we are also working with ISRO. We have that is, we are doing field validation, ground validation for their satellite missions, especially the OCM3 sensors, which they have launched now. And now, as Stefano said, they are also focusing on webinar lake. So that's another area where we are also collaborating with them.
Yeah. Actually, this is a very good discussion. I would have liked to continue, but Ravi, you want to come in, because I think we are on the almost getting close to the hour. Ravi.
Thanks,
But I
Kushi.
want you to still mention about GHFD and maybe the work that Jojo talked a little bit about the ramp and capturing satellite imagery, population estimates, and accessibility, if you can. But otherwise, yeah, go ahead. Thanks, Ravi.
I know that we are very short of time. We have only 2 minutes more, but interesting presentation. As Stefano said, I think the key thing is how do you build these collaboration? How do you make people aware that these tools and technologies are there? And you also have partners on this side, like the European Space Agency is supporting various activities in India. So I think that is a key message from the whole discussion here. We'll also like to bring that ISRO, ISRO into the picture soon, so that we could have discussions with both ESA and ISRO and the partners. I think that should be one takeaway from our side, also to make that bridge strong and have that exchange of information to benefit the NGOs and our partners there. On the point of GHFT, GHFT is a simple initiative, very simple in the sense like you just need like 3 or 4 parameters, like the name of the facility, the type of the health facility, the location, with a unique code made public in the ministry's website. That's subjective. We are aiming that 194 countries can make this possible, so that all our partners can use single source of truth. Because what happens is every country, every place, everybody goes, we start immediately collecting these data sets. And there's no way that you could have the updated data sets if we go and collect by ourselves, because every day dynamically these things changes. New facilities come, facilities close, or they upgraded, downgraded, all these things happen. So we are embarking into that, and we would like to send more information about that and see how our partners can also help us on that. So if people want to help, the way it will is, we'd like to engage them with the ministry and the WHO country office, so that we make the bridge, so that we can all contribute to the good common cause. First, I'd like to thank Paul and Sophia on the efforts to make this event happen. If you guys are aware that last week was a fabulous week in Geneva, where we had all the activities happening on the World Health Assembly, where key discussions were happened there. Then we had the digital week, where we had Paul, we had ESA, we had all other groups mixed here. We had a hackathon, we had the AI for Good in Geneva. So many things were happening on the area of digital, and GIS was spoken in every aspect of their people's discussion. Even the hackathon, it is geospatial and health was the key theme. So we had fabulous participants out of 13. I was talking with Stefano, he said that more than 5 to 6 or close to 8 of them have potential to be a project by itself. That is the main idea of the hackathons, to make it into a real-time projects that people could benefit. And I also see that Paul has joined. Maybe I'll give the floor to Paul so that he can do the thanking remarks. Over to you, Paul.
No, Ravi, the thanking remarks will be done by
Maybe I will do the closing.
Yes,
and
go ahead,
the
Sophia.
thank you remarks.
I'm here just to say goodbye to everybody, and thank you so much, Ravi, for the effort in putting this panel. As Sophia explained, we had a major technical issue this morning, similar to yours. But I've been following this via LinkedIn Live, where we have a few viewers, and it's going to be replayed next week. It's an amazing session. thank you, Ravi, and thank you all participants. And now over to Sophia, so she could do the closing as we initially planned. And of course, thanks to my team at Data Forum for doing incredible work here today. Thank you all.
So thank you all on behalf of Health Data Forum team. Thank you so much, Ravi, for the effort you put into putting this whole session together. And thank you for all the participants, because it was truly an inspiring session. I think that we have some key elements here that we all agree on. Collaboration is key. We must all connect and really share these beautiful pieces of work that you've all been putting together, because these strategies are actually being done now in very specific settings. But I think that when we can control these technologies a little bit better, it will be key to making health better for the entire planet. And the approach, as Nandini very wisely put it, the one planet approach is where we should all be going to. So thank you so much, everyone. Thank you so much for being here. And thank you to our viewers. And I hope you can all keep connecting and sharing our experiences. Thank you.
Thank you.
Thank you,
Thanks, all.
Sophia.
Bye-bye.
Thank you all.
Bye-bye.
Bye.